Can you all see my slide?
Yes, doctor.
Yes.
Ethan, how do I go back to? Okay. So today we're going to talk about pulmonary embolism, mainly on pathophysiology. Actually, just a little bit on treatment. I don't know why the topic was put like that in treatment, but we do have treatment in the learning outcome. Okay, so it requires a bit of recall on your general pathology on the thrombosis. Okay, did you all get my notes? I have uploaded it in the Teams. So I hope you all have gone through the notes before this. Okay, just very, very quickly on the learning outcome, recall the Virchow's triad. You have to know a bit on the risk factors of pulmonary embolism, the pathogenesis of pulmonary embolism, okay, and the pathophysiology of pulmonary embolism, okay, and the clinical presentation are related to the pathophysiology. And we are also going to go through a bit on the investigations and discussion on the treatment. So it's a bit clinical in a way, but we want to also concentrate on the basic science of it, which is the pathogenesis, pathophysiology, and the pathophysiology of the clinical presentations. Yeah? Okay. Okay. So what is pulmonary embolism? I think in the general pathology, we talk about a bit about pulmonary embolism when we talk about thrombosis, okay? So it is a condition where there's blood clots or thrombus, or it can be in a form of a single thrombus, or it can be in a form of multiple thrombi, okay? Migrating from the systemic circulation, okay? So because it's emboli, it's actually from migration of this clot from systems into the pulmonary vessel. All right. So most of the clots arrive from the deep veins of the lower extremities, okay, from the lower extremities, but you may have clots arising from the upper extremities, okay. So it is actually relatively common. Okay, we do see pulmonary embolism from time to time. It is a relatively common condition, but it actually can be easily missed in real life. Okay, it is probably more than what we've seen. Okay, so in fact, we saw a lot of pulmonary embolism when we discover it during autopsy. Okay, so it is something that you can be easily miss clinically. So that is why actually it's quite common, can be easily missed if you don't suspect pulmonary embolism. Okay, because you will need specific investigation for you to be able to diagnose pulmonary embolism. Okay, so you need to suspect pulmonary embolism first, then only you will direct your investigation toward specific diagnosing pulmonary embolism, because most of the time your routine investigation you won't pick up pulmonary embolism. So it requires suspicion, okay, which involve the combination of knowledge of the risk factors as well as the knowledge of signs and symptoms. So you will come to know later that they might be asymptomatic, yeah, or it might be very minimal symptoms. Okay, they can come just with tachycardia, for example. So you really have to dig whether this patient has a high risk of pulmonary embolism or not. Then only that will lead you to specific investigation for pulmonary embolism. Then only you can treat accordingly. Otherwise, it can be easily missed, especially in emergency departments. So we have a lot of discovery of pulmonary embolism during autopsy. Yeah, so it is a quite common condition, can be easily missed. Okay. All right. So let's recall Virchow's triad. Anyone can explain what Virchow's triad is? Very, very briefly. What are the three components of Virchow's triad?
Hypercoagulability.
Hypercoagulable state. What else?
Turbulence or stasis of blood flow.
Okay, so the blood flow. Another one.
Endothelial injury.
Endothelial injury. Okay, so we say if there's endothelial damage, or if you want to broaden your spectrum, is any endothelial abnormality. Okay, because we learned before, it is not necessary damage, but if you have abnormality to the endothelial lining, you will have a disbalance in the factors or substance that is synthesized by your endothelial cell. Okay, so these three, so you go back to all these three Virchow's triad, which explain the probability or the risk of a person to form a thrombosis. What about the fate of this thrombosis? See, if a thrombosis occur, okay, in a person, what are the fate of this thrombosis? Again, it's a recall. Anyone? What can happen to a thrombus?
Becomes an emboli.
Okay, it can become an emboli. What else? This is just a revision.
Lead to atherosclerosis.
Atherosclerosis, okay. Atherosclerosis need another process, right? Okay. But what are the fate of this thrombus? What can happen to this thrombus? It can break and move and become emboli to other place. What else?
Propagation.
Propagation. What does propagation means? It increases.
It's in size, yeah.
It's increased in size. Okay, what else?
Recanalization or resolution.
Okay, so it can recanalization. So there's the formation of holes within the thrombus itself. So it can resolution. So that means it can resolve. Okay, another one. Apa lagi satu?
Broken down by fibrinolytic agents.
Okay, so that is resolution. It's broken down by fibrinolytic. Yes, so all the small thrombus, in fact, the small emboli can actually dissolve. Okay, by the natural inhibitors. Another one is organization. Okay, it can organize and it forms, and it can bury in the inner layer of the vessels. Okay, so this is just a revision, the fate of thrombus. Okay, so in this case we are talking about if there's a lot, if the thrombus is big enough and there is not enough adherence to the endothelial lining. Okay, so we say that if it's big enough, not enough adherence, the tail part of it usually are very loose and it can move and emboli. Okay, so this is when pulmonary embolism occur. So where does it usually occur? Where is the common place that the pulmonary embolism comes from?
Deep veins.
Deep veins. Okay.
DVT.
It comes from the deep vein thrombosis. Okay, so where does deep vein thrombosis occur? Usually
The calf.
from the calf. Okay, so it is from, usually most of the time, about 90% of the time, it is from the deep vein of your lower extremities, or DVT, which is from the level above the knee. Okay, it's from the calf. So So those which is above the knee has a higher propensity to migrate and cause pulmonary embolism. Okay, so it can be from the popliteal vein to your femoral vein to the external iliac, and then the common iliac, and into your IVC, right atrium and right ventricle, and go to pulmonary artery. Okay, so for you to understand this, you have to be able to imagine how it moves first. Okay? Okay, so I hope by this point, all of you can, so we've talked about this already, yeah? The pathogenesis. You have to know the pathway of how it travels. Okay? All right, so basically through this way, and you have to know how it gets into the heart. So go back to your cardiovascular, how it gets into your heart and moves from the right atrium, right ventricle, and it goes into your pulmonary circulation. Okay, so it goes into your pulmonary artery. Yeah, pulmonary artery, and depending on the size, okay, it can start at the bifurcation of the pulmonary artery. So this is when we call it saddle embolism, the big embolism which start at the bifurcation. Or if it is small enough, it can travel into a smaller vessel, okay, and will go to a more peripheral part of the lung parenchyma. Okay? Okay, so you have to know the pathway. You have to know how to describe how it moves from the veins, from the lower extremities to the heart and to the lung. All right, so okay, so most of the time it is from the deep vein of the calf. Okay, but it can also come from the pelvic veins, because we will talk later that a risk factor for pulmonary embolism include also abdominal surgery as well as pelvic surgery. Okay, in pregnancy, okay, it can travel through pelvic veins. Okay, a pregnant lady with high risk factor because they are at a hypercoagulable state. Okay, especially pregnant lady who undergo surgery. Okay, they're at a higher risk. Okay, so it can travel through pelvic veins. Okay, we talked earlier, it can also come from upper extremities, especially when we have a central venous catheter. Okay, from the central line, intravascular cardiac devices, so it can travel through this pathway. Okay, we can also have a thrombosis formed in the right ventricle. This is very, very rare. Okay, so it doesn't travel from the systemic, but somehow if there is a thrombosis primarily in the right ventricle, so it can easily go to your pulmonary circulation. Okay, but this is very, very rare. Most of the time, most of the time, it comes from your DVT. Okay, from the deep vein of the lower extremities. Okay, so that's the sources of emboli. These are Virchow's triad. I'm not going to go through this. Okay, so we talk about risk factors. Okay, so basically the risk factors for PE is the same as the risk factor for DVT. Okay, because we say most of the time it is from the patient with deep venous thrombosis, right? So if we go through the risk factors, it usually is divided into major and minor risk factors. Major risk factors are a person who undergo surgery, okay, especially lower limb surgery and major abdominal surgery. Why surgery? Anyone? Why surgery is a major risk factor?
It can cause endothelial damage.
It can cause endothelial damage. What else?
Activation of the coagulation cascade.
Activation of coagulation cascade, okay. because the manipulation during surgery. What else?
Spread of bacteria.
Sorry?
Spread of bacteria.
Spread of bacteria. Okay.
For
What
example,
else? Yes?
like in the case of IE, I think infective endocarditis, at times you can have pulmonary embolus as an outcome.
Okay. All right. Okay, you can have emboli in the case of IE. But what about surgery? I'm asking why surgery particularly is a risk factor. Besides, you've explained about endothelial damage and all that. What else? Why surgery?
Is it because you stay in bed for a very long time?
Yes, because of immobilization. Okay, you know, patients who undergo surgery, especially lower limb surgery, they're not allowed to move. They tend to stay in bed for a long time. Okay, so that's why they are at a higher risk. I mean, not only the formation of clots is increased because of endothelial manipulation, okay, endothelial damage, increased information of thrombus, but at the same time, they are immobile as compared to the normal person. So the longer you stay in bed, the longer you are hospitalized, the higher risk you are to get thrombosis as well as embolism. Okay, so they need to be in some kind of a prophylaxis usually. Okay, so immobilization that's contributes to all these risk factors. Okay, obstetric. Okay, so we know pregnancy lady is in the higher hypercoagulable state. Okay, so especially so if they undergo surgery, for example, cesarean section. What is LSCS? LSCS is a lower section cesarean section. So it's a cesarean section, okay, or preeclamptic. So they tend to get a higher risk of PE. Malignancy, okay, especially a patient with malignancy, you tend to get thrombosis, hypercoagulable state, okay. So more so if patient with malignancy undergo surgery or procedure. Okay, so pelvic malignancy of abdominal malignancy. Okay, so these are all hypercoagulable state. Okay, lower leg fracture, varicose vein. Okay, previous history of venous thromboembolism. So these are the higher risk, but of course we have minor risk. So these are those you say the IE, patient with heart failure, congenital heart disease, hypertension. So these are the risks that can add in for the occurrence of PE. Okay, so we can go through all these risks. So typically, it has been reported women aged more than 30 on OCP with and who smokes, they have a high risk of getting PE. Okay, so it's a combination of everything. Yeah. Okay, so risk factors is important for you to be able to suspect PE in a patient. Okay, because we will learn later that their sign and symptoms, clinical manifestation or presentation can be quite general. Okay, so you have to have a high suspicion. So that's why you need to know the risk factors. Okay. Okay, I don't know why I put this slide. Can economy class syndrome? I don't know economy class syndrome because we say that the DVT occur a lot in a patient who travels. Okay, probably this was also in the previous slide in general pathology. I'm not sure. So there was a study that is done. It's actually quite a large study. They study. It was done in 2001 on 135 million passengers. So it's a huge study. So they found that those who travels more than 10,000 kilometers, there are about 5 cases per million of DVT. Okay, so they found that the longer you travel, there's a higher rate of DVT. Okay, and they also do the same with patient with who are watching TV. Okay, who are immobilized with an equal time with those who are traveling. So these people who sits watching TV has a lesser risk than those who travel. So they found that probably the change in the air quality put them in a higher risk. So that's why we say who travels have a higher risk. So probably it's not only because of immobilization, it's also because of the air quality environment when you fly. Okay, contribute to it. This is just an info, yeah. Because you always ask, what about when we say when you travel long distance traveling, you tend not to move. Why are you at a high risk? And but what about if you stay put so long, not moving, playing game for hours, but you don't have a risk? Okay, it's actually you're at the lesser risk, okay, than those who flies. Okay. So pathophysiology. Okay, so what happened when you have PE? Okay, so there are 3 major things that you need to understand that can happen in pulmonary embolism. Okay, so first I want you to understand the hemodynamic consequences. Okay, this hemodynamic consequences is because of increase in pulmonary vascular resistance. Okay, because you have a blockage there, so you have increase in resistance of your pulmonary vessel, right? Increase in resistant pulmonary vessels, and that will lead to hemodynamic consequences. Okay, so first, because of the blockage, okay, and bear in mind this blockage in itself is not just blockage. There will also release of mediators like the thromboxane A2 and serotonin, which will further cause vasospasm. Okay, so on top of just blockage, on top of just mechanical blockage, okay, pulmonary embolism, there will be also release of mediators, cytokines, okay, which will lead to vasospasm, also bronchospasm. Okay, all right, so all in all, this will lead to increase in pulmonary artery pressure. Okay, so what happened when there's increase in pulmonary artery pressure? Okay, so you have to go back to your CVS. Now you have to go back to your CVS. Increase in pulmonary pressure, there'll be increase in right ventricular pressure. Okay, so increase in right ventricular pressure, there will be decrease in cardiac output. This will lead to right heart failure. Okay, so eventually this will lead to decrease in the left side of the heart. Yeah, so will lead to decrease in left ventricular cardiac output. So this will cause cardiovascular collapse. So these are the hemodynamic consequence of pulmonary embolism, which usually occur if you have large pulmonary embolism. Okay, it doesn't occur if you have small emboli which lodge at the periphery of the lung. Okay, pulmonary hemodynamic consequences usually occur as an emergency consequence if there is a large pulmonary vessel occlusion. Okay, for example, in saddle embolus. Okay, so what happens when there's an increase in right ventricular pressure? You will also have a bulge on the intraventricular septum because of increase in pressure. Okay, so they will lead to decrease in left ventricular filling. Okay, and you can also have compression to the right coronary artery, which can lead to right ventricular ischemia. Okay, so decrease in left ventricular filling, we talked about it before, which lead to decrease in cardiac output, and then you can have cardiovascular collapse. Okay, you can also have compression of coronary vessels, which lead to right ventricular ischemia. So you can have myocardial ischemia. Okay, so these are the hemodynamic consequences of pulmonary embolism, which is usually caused by large emboli. Okay, so you all got that? All right, so this diagram shows what can happen, okay, due to increase in pulmonary vessel, increase in pulmonary vessel pressure, which lead to right ventricular afterload. Okay, so these are the whole consequences that can occur. So it starts from right ventricular dilatation, go all the way to cardiogenic shock, and you can have sudden death. So this is when probably they come to ED and we fail to diagnose it, okay, because it can be quite sudden. Okay, so along the way, there's a lot of things that happen. Right ventricular dilatation, increase in wall tension. There's also neurohormonal activation comes hand in hand. Okay, so with all this tension, there's also increase in oxygen demand. So that means on top of that, you might also have right ventricular ischemia. So we talk about maybe compression of the coronary vessel, but at the same time, with increase in ventricular tension, there's also increase in oxygen demand. So that combination will lead to ischemia, and because of ischemia, so it will also lead to decrease in contractility. So all these are the vicious cycle of what can happen when you have increase in right ventricular pressure. Okay, so along the way you will have decrease in blood pressure. So this is one of the sign. Okay, so when you have when you find a patient with dyspnea and BP is already dropped, so you have to actually check for PE, and this already probably the stage of going into cardiogenic shock already. Okay, so because of this as well, you can have tachycardia, okay, low cardiac output, low BP, and you have increase in heart rate. So that is another sign and symptoms, sign of heart failure. Okay, you have tachycardia. So they can come with tachycardia, dyspnea. Okay, and once the BP is low, you have to really act very fast. Okay, so that is the hemodynamic consequences of pulmonary embolism. Okay, so another important consequence is hypoxia. Okay, of course, because now we are talking about lungs. Okay, we're talking about decrease in perfusion to the lung. Okay, so all this happened because of VQ mismatch. You all have learned about VQ mismatch in physiology, right? Yes, yes, yeah. Okay, so I suppose you know about VQ. What is a normal VQ? What is a normal? Ada ke normal VQ? What is a normal VQ?
That's the average, 0.8.
0.8 to 1.2.
Okay, so it's around 1, yeah, 0.8 to 1.2. So you have to have a match between ventilation and your perfusion. Okay, so how does VQ mismatch occur in in pulmonary embolism? Anyone wants to explain?
When you have a blockage of the pulmonary capillaries by an emboli, you're going to create, the perfusion of the alveoli is going to decrease.
Okay.
So you're going to have this thing called alveolar dead space, where alveoli are ventilated but not perfused, so there's no gaseous exchange. So there's basically a ventilation and perfusion mismatch, because there's no perfusion, so the VQ ratio is undefined.
All right. Okay. What else can happen? So that is one. There are a few factors that contribute to this VQ mismatch. Okay. The increase in dead space, yes, because simply decrease in perfusion. Decrease in perfusion, so you will find area in which there is ventilation and but there is low perfusion. Okay, so that is called dead space. What else can happen? What else can contribute to the VQ mismatch?
You decrease the.
Sorry? Okay. Yeah, all right. You will have an area, okay, just when you talk about decrease in perfusion, in this case, yeah, yes, there is decrease in perfusion, right? So you're right, there will be increase in area of dead space, okay, because you will have area in which you have ventilation, but there is no perfusion. But where would the blood go?
You have a right to left shunt.
Yeah, so the rest of the blood, which are blocked, it will go to the other area of the lung. So you will also have the area in which a lot of blood, but less ventilation, right? So that's where the mismatch comes about. You know, you will have the mixture of area with of dead space, one, and the mixture of area with a lot of blood shunted to to one part of the to only one part of the lung. So you have area in which there's a lot of blood flow because of the shunting, okay, and low ventilation. So that means more flow than the ventilation, right? Because the ventilation is not affected. Okay, so the mixture of this contribute to the mismatch, because eventually this will sum up into how much PaO2 is in the blood, right? Okay. So because when you talk about this, if you are talking about a place where there is low perfusion but increase in ventilation, the result of the blood vessels that flow to that area, actually the oxygen saturation is quite high, isn't it? Because the blood flow is very little, because the blood flow here is actually the non-oxygenated blood, right? So it meets the alveolar to get the oxygen from the ventilation, right? So the end result is oxygenated blood in the vessel. Okay, so if you have less perfusion, we are talking about if you don't have any perfusion at all, yes, okay, then there is no result of oxygenation in the blood. But if you're talking about the less blood flow to an area with more ventilation, actually, you in that blood vessel, okay, you will actually have quite a high oxygen saturation. Do you get what I mean?
Yes, yes.
Because ventilation is high, perfusion is low, right? So that particular vessel, that particular area of lung parenchyma, okay, the vessel which go to that area, these few vessels that go to that area actually get a lot of oxygen, right? The outcome, as opposed to the place where there's a lot of blood, but the ventilation is only that much. Okay, so a lot of blood that goes into this area will, because they have to share, so the outcome of this part, the oxygen saturation is actually less. Do you get what I mean? Because more blood, but ventilation is less. I mean, ratio wise. Okay, so the overall result of the oxygenation for this area, the oxygen, if you measure the oxygen of the blood vessel that come out from this area, will actually be less saturated by the oxygen, because a lot of blood but less ventilation. So the mixture of this eventually actually will result in decrease in PaO2. Okay, this is when the mismatch comes about. Okay, the mismatch is actually telling the mixture of area with high VQ and low VQ. Because if you talk about that space, actually the VQ is high or low? VQ ratio is high or low?
Very high.
High.
It's very high, right?
Very
High
high.
VQ ratio. Okay, but in place where a lot of blood shunted to that area, the VQ is low.
Yes, doctor.
Right? So we have a mixture of area with high VQ and low VQ, but end up you will have low in oxygen saturation, because more blood won't get oxygenation, right? Okay, so on top of that, you also have ischemia of lung parenchyma. We're not talking about what you call it. We're not talking about infarction, but you will have because of the decrease in perfusion, some of the lung parenchyma got ischemic, and there's increase in surfactant, so you will have area of alveolar collapse, okay, which also contribute to this VQ mismatch, okay, and we also have, we mentioned earlier, there's also a release of mediator because of this thrombose. Okay, so you have vasoconstriction and bronchoconstriction, so which will lead to alveolar hypoxia. So all in all, this will lead to hypoxemia. When we say hypoxemia, that means we say decrease in oxygen in the blood. Okay, you understand? When here we say alveolar hypoxia is decrease in oxygen in the alveolar. So all these factors, okay, the main one is the upper one. When we talk about decrease in perfusion, so we have area of dead space and you have area of increase in blood with low perfusion. But bear in mind, there will also be area of alveolar collapse, okay, which you will have deranged in the VQ as well, and you will have area of bronchoconstriction itself, in which you will have decrease in Q and decrease in V. Okay, so area of alveolar hypoxia. All right, so there's a mismatch. The idea is there is a mismatch of VQ. All right, and the result of this, the overall result is you will have arterial hypoxemia. So that means your PaO2 is low. When you do your ABG, your blood gas, you will see that PaO2 oxygen in your arterial is low. Okay, I think you learn in your physiology as well. When you have hypoxemia, you will tend to have hyperventilation, right? Then hyperventilation, you will have hypocapnia because you hyperventilate and you will release your carbon dioxide. Okay? So you all understand this? Faham? You need to understand this concept. So the whole VQ mismatch will eventually lead to arterial hypoxemia. Okay, so there are hypoxia, arterial hypoxemia, which will lead to hypocapnia. So when you have hypoxemia, hypocapnia, you tend to have respiratory alkalosis. Yeah. Okay, so that's number 2. Okay, number 3 is pulmonary infarction. Okay, pulmonary infarction is rare in pulmonary embolism. Although we want to think that yes, there is a blockage of perfusion, so it will lead to infarction, but it is not. It doesn't usually occur in pulmonary embolism. Why? Because we learned before in the different types of infarction in general pathology. So you go back to the different types of infarction. So typically in lung, you will have a hemorrhagic type of infarction. Okay, because in the lung, you don't only get your oxygen supply from your pulmonary artery. Okay, you will also have oxygen from your bronchial artery. From your aorta, okay, branch of your aorta which supplies oxygen to the lung as well. Okay, and you also have a lot of oxygen from your alveolus as well. So it is not easy actually for a lung parenchyma to have infarction. Okay, unless there is cardiac function compromise or there is underlying pulmonary disease in which these other factors, okay, the bronchial artery supply or the alveolar oxygen is less, is deteriorate. Okay, so only when you have this other condition on top of pulmonary embolism, then only you will get infarction. Okay, so usually it occurs in the lower lobe. Okay, why lower lobe?
Because of gravity.
Because of gravity. Okay, so usually if you have a decrease in supply, usually it will be affected by the gravity. Okay. Okay, so it is mainly if it were to occur, usually it occur in lower lobe. Of course, it can occur anywhere in the lungs. Okay, but mainly in the lower lobe. Okay, and then it will occur in a form of hemorrhagic infarct. So what will happen is actually it will start with coagulative necrosis. Okay, I think I have, yeah. Okay, you can see it's black in color. Okay, so usually it is is a wedge shape. Here the wedge shape is not clear, but usually is, if you can imagine, is wedge like this. Okay, so the base of the wedge is triangle. Wedge is a triangle shape. So the base are the pleura. Okay, and the apex is usually where the point of the block is. Okay, here is not that clear. Okay, but if you can imagine, is like triangle like this. Okay, so if you can see here grossly, it is dark in color. So if you look under the microscope, it's actually coagulative necrosis. What is coagulative necrosis? General pathology. All these questions will be asked back in your pro, you know. So what is coagulative necrosis? Anyone?
It's like the type of necrosis where there's denaturation of the protein, I think, and the enzymes. There'll be like death of the cells, but the same structure will be maintained. You can still
Okay.
tell this is a heart cell, for example.
Okay, good. Okay, so example, in general pathology, the example of coagulative necrosis that you have in your slides are your heart. Okay, your heart. So this is when the cell is not, the nucleus and all is not there because it's necrosis. Okay, but you can still see the structure, the framework of the organ. Yeah. In the heart, for example, in the heart. Okay, so it's a coagulative necrosis. Okay, so the early part is coagulative necrosis, but eventually you will see there's a large amount of red blood cells, and because of there's a lot of red blood cells, you will see hemosiderin and all that. Okay, and eventually it will become scar. There will be fibrins, and there'll be fibrinous exudate, and the infected part will become a scar. Okay, eventually later. So all this will replace with fibrin. Okay, so you will see area of coagulative necrosis with large amount of red blood cells in it. Okay, if you can appreciate all these are red blood cells, so that's why grossly it's red or dark lah. Okay, because red blood cell, then it will become hemosiderin. Okay, okay, so that is a pathology, morphology of it. All right, so yeah, so these are the 3 consequences. Okay, 3 consequences of pulmonary embolism. Okay, so what are the signs and symptoms? Okay, most of the time they are asymptomatic, especially those with small emboli. Okay, those with small emboli is asymptomatic. In fact, 60 to 80% of pulmonary embolism is because of small emboli. So you can simply miss it. The small emboli can easily dissolve by the our natural inhibitors in the body. Okay, some who are still there lodge in the so small emboli, it tend to lodge more periphery. Yeah, so you won't have this hemodynamic. You won't have hemodynamic consequences. So you truly, usually you won't have any sign and symptoms. Okay, so there is no problem with it. Okay, but if you were to have symptoms, okay, so what are the symptoms that you can have? First, you can have dyspnea. Okay, so dyspnea or tachypnea. Okay, in a massive PE, massive pulmonary embolism, you can have acute dyspnea. Okay, severe isolated dyspnea means you can have only dyspnea. Okay, and it is acute dyspnea. Okay, in a small peripheral PE, you can have a transient dyspnea because we're talking about the small area which is not ventilated, perhaps. Okay, and you can also have what we call a progressive kind of dyspnea. So you can have small periphery pulmonary embolism that is there, you can have multiple pulmonary embolism which is recurrent. Okay, so you have in a person who have recurrent pulmonary embolism. So it is resolved, and sometime later they will develop again the small PE. Okay, so there are many ways that the PE can occur. So it's either can occur chronically, is always there, small pulmonary embolism, but it doesn't do much. But eventually you will develop mild dyspnea, because eventually that place will have atelectasia or some VQ mismatch to that area. Okay, but it is not like it won't go into a hemodynamic effect, because it doesn't really cause increase in right ventricular pressure. Okay, but in massive PE, you can have an acute dyspnea. Okay, or you can also have a person with recurrent PE. Okay, usually you will have a multiple area of small area of the lung that you will see the dislodge of the small emboli. Okay, so you have a progressive dyspnea. So that means it starts with mild, and then it become worse and worse and worse, something like that. So, but it doesn't really matter. What you have to know that they will have dyspnea. Okay, doesn't really matter. You will have dyspnea, but dyspnea can come with different style. It can be acute. So the different style of dyspnea is more clinical for you all. Okay, but just know that you can have dyspnea. This is because of hypoxia. Yeah, it's because of hypoxia. So you have to go back to what we discussed earlier. How does hypoxia comes about? Okay. Chest pain. Okay, what kind of chest pain that they have? They can have pleuritic chest pain. Okay, because of irritation to that area of the lung. They can have what we call a pleuritic chest pain. Okay, usually it occurs when there is infarction and hemorrhage. When there's infarction and hemorrhage, you will tend to have chest pain. Okay. So if you have infarction as well, you can have hemoptysis. What is hemoptysis?
Cough up blood.
Okay,
Cough
you can
blood.
have. Okay, you can cough up blood. Okay, so usually if you have infarction and hemorrhage at that area of the lung, okay, you will have pleuritic pain. Okay, because of irritation of that area of the lung. Okay, usually this is caused by medium or small size artery, or it can be a retrosternal chest pain because of infarction. Remember, we talked earlier that you can also have ventricular infarction. So this can also contribute to the chest pain. Okay, so that is another symptoms that a patient can come with, right? Okay, and the third one, they can have a circulatory collapse. This is in massive PE. Okay, so when do you get this syncope or circulatory collapse? You can get it usually when it involves more than 60% of pulmonary vasculature. Okay, if it's only involved, if the PE only involve 10 or 20%, you won't have the circulatory collapse or shock. Yeah. Okay, so they can come with dyspnea only. Okay, dyspnea means they can come with tachypnea, and they can complain of chest pain, or they can come to ED already collapsed. Okay, that is so in massive PE, it is actually an emergency condition. So these are the symptoms. Okay, what about the signs? Okay, so because of dyspnea, you can have tachypnea. Okay, so we talked about hyperventilation just now because of hypoxemia. Hyperventilation which lead to hypocapnia. Okay, and you can have tachycardia. Okay, because remember we say decrease in cardiac output. they can have tachycardia, okay, they can come hypotensive. So the moment they have low in BP, you have to be very, very cautious, okay, because we're talking about the hemodynamic consequences. So it might be a large infarct already, or it might be a progressive type, which is the small one, which become worse, okay? And you can have the signs of right ventricular pressure, a signs of increase in right ventricular pressure, okay? So back to your CVS, what are the signs of increase in right ventricular pressure? Right parasternal heave, increase in JVP, okay? So if it's bad enough, they can come with a cyanosis. This is when the SpO2 is low, okay? Usually their oxygen saturation is normal, but if it's severe enough, when there's oxygen saturation, okay, SpO2 is when you put the pulse oximeter, okay, patient come and you put the pulse oximeter on the finger and you see the oxygen saturation. So that is SpO2. So it's different from when we say PaO2, when you measure from your ABG, from your arterial blood gases. That one you have to take the arterial blood samples and you test in a machine and you get the result of your PaO2. Okay, but that your SpO2 reflect your PaO2. Okay, so it reflects hypoxia. So oxygen saturation. So patient can come with cyanosis. Okay, patient can have fever because of inflammation. Okay, there will also be inflammatory process. Okay, with the pulmonary embolism, embolism. Okay, and you can also look for the sign of DVT. Okay, so these are the signs. Okay, so just now it was the symptom. Okay, so these are the signs. Is it the signs? Or I got it mixed up, the sign and symptoms. Betul lah. Yeah, the signs. You have to look for the signs. Okay, I got mixed up. All right, so these are the signs and symptoms. Okay, so symptoms-wise, they can be asymptomatic. Okay, so you can easily miss. Okay, but the moment you check the patient, the patient can just come with dyspnea. Okay, so you want to check the patient. Okay, so if you listen to the lung, what would probably be your finding? If you do the physical examination and you want to listen to the lung, what do you think would be the finding? Anyone?
Decreased breath sounds.
Decrease in breath sound. Okay. Yes. Normally, it's normal. Okay. Normally, your physical examination of the lung will be just normal. Okay, because there's no consolidation, there's nothing. Okay, but unless they have area of lung collapse, okay, or infarction, okay, this is when you get a decrease in breath sound to the certain area. So generally, it will just be normal. Okay, because we're not talking like pneumonia when there's area of consolidation in which you will have area of decreased breath sound, or it's not like asthma in which you can have mechanical obstruction of the airway when you have wheezing. Okay, so it's nothing like that. So another suspicious is when you have patient with dyspnea, and then when you listen to the lung, it's basically normal. The air entry is normal because ventilation is unless if there is atelectasia, okay, in which usually is only some part of the lungs only. Okay, it's not like the total lung collapse. Okay, but most of the time they are hypoxic. They can come with dyspnea, tachypnea, but when listen to lung is normal lung finding, okay? And they are tachycardia. So yes, you have to start to go to the risk factors to be able to come up with the possibility that possibly this patient have pulmonary embolism, okay? All right. So, okay, sign and symptoms, okay, yeah? Okay. All right. So these are just the profile of what they find. They can come with so many things, but normally dyspnea, chest pain, tachypnea, tachycardia. Okay, which is actually quite a general non-specific symptoms, actually. That's why suspicious is the key in getting the diagnosis. Okay, so you might not have DVT even. You might not even find DVT in this patient. Okay, because you see only 15% of the patient with PE you will see the sign and symptom of DVT. Okay, so it doesn't usually connect well DVT chest pain because you might not see DVT. So they will just come with a chest dyspnea or tachypnea, and if you check the pulse rate is high, okay, only about 50% come with chest pain usually. So most of the time they can come only with dyspnea, okay, dyspnea, tachypnea, and they will have some sort of tachycardia. Okay, all right. Go back and study this. This actually, I don't want to go through this, so it's the same explanation. This is I found it a very helpful diagram to link the whole thing that we discussed just now on the pathophysiology. Okay, so you go back and you try to digest this. Yeah, okay. All right. So this is when we talk about just now before we investigate. Okay, which way are we going to investigate? This is what I mentioned just now. You need to have a high suspicion that this patient have PE. Then only we will direct your investigation accordingly. Okay. Do you all want to continue or you all want to take a break?
Can we have
It's
a
10
break,
o'clock.
doctor?
Okay, sure. We have a 10-minute break. Yeah, because I think we can finish on time. We have a 10 minutes break.
All right, thank you, doctor.
Okay.
All right.
Okay, are we all here? What time you want to start actually? Now it's 10:20. Do you all need more time?
I think we can continue, Doctor.
Yeah, semua
I
dah ada.
think
Yeah? Okay. You all have lectures at 11, right? Is it 11? 11:30?
11:30.
yeah,
Oh.
11:30.
All right. Okay. Can you all see my slide now?
Not yet, doctor.
Not yet. What do I do? Have to share again, is it? Show that in this. Okay, let me see. How do I go back to my slide? Okay. Can you all see my slide now?
Yes, we can.
Nampak? Okay.
Yeah.
So, all right. So we're down to actually investigations and investigations and treatment. Yeah. Okay. So I mentioned earlier that you need to have high suspicion. Okay. So clinically, there are a few guidelines on how they use to identify or classify patients, whether they are likely or less likely to have PE. Okay, in order for them to direct to proper investigations. Okay, so there are what we call this is a score that has been developed, which is called Wells score, that is used in the ward to see whether how likely that this patient probably have PE. Okay, actually there are two versions. The modified one, I'm not quite sure whether these are the modified one or not, but this doesn't really matter because you will deal with it more when you're in clinical years. Okay, I just want to show the variable that is used in the Wells score. Okay, so what they will look for is whether the person has a previous DVT or previous PE or not. So with that, they get like 1.5 points. Okay, and whether there is surgery or immobilization, whether they have cancer, whether there's hemoptysis associated with it or not. They look at the heart rate. If the heart rate is more than 100, so they get points also. Okay, is there clinical signs of DVT? Alternative diagnosis less likely than PE, meaning is there any other possibility that this patient have these signs and symptoms? For example, if there's pneumonia or pneumothorax or heart problem, that can also lead to the dyspnea. Or if the patient have asthma, for example, patient comes with dyspnea, for example, right? Shortness of breath. Okay, so you see, is there any other thing in this patient that's suggestive that that can cause this dyspnea? For example, is the patient have pneumonia? Does the patient have heart problem? Okay, if you have these other criteria, then you cannot give this point. Okay, but if you cannot rule in other causes than PE, then only you can give this score. So all in all, you sum up the points that you give, then you can interpret it or translate it into whether it's a highly suspicious, intermediate probability or low probability of this patient having PE or not. Okay, so if you have low probability, so maybe you won't proceed with investigations for PE at all. You know, so this, because all these criteria will add into the diagnosis to the investigations. Okay, so what sort of investigations that you can do? You can do chest X-ray. Okay, chest X-ray, because of course when a patient is having shortness of breath, the most easy, quick, cheap, maybe easily available, non-invasive test that you can do is chest X-ray. Chest X-ray is very easy. Okay, even if a patient is not in emergency department, they can bring the mobile chest X-ray and do the X-ray in the bedside. You know, so chest X-ray is easy and quick. If a patient is unstable to move around, you can do mobile chest X-ray. Okay, but the problem with chest X-ray is in pulmonary embolism, usually it's normal. You hardly see anything in pulmonary embolism. It is more useful to rule out other lung abnormalities. Okay, for example, it is more, you can see pneumonia if it's there. You can see pneumothorax if it's there. You can see pulmonary edema if it's there. Okay, so it is more useful to rule out other causes of the dyspnea that the patient presenting it. Okay, if otherwise, if it's just pulmonary embolism, most likely you won't see anything. Okay, because it's just a matter of decrease in VQ mismatch without any physical changes on the lung parenchyma. I mean, any significant changes in the lung parenchyma, really. Okay, except for just minor changes in which you might not see in the chest X-ray. Okay, so but what are the things that you can see? Right, there are few non-specific changes. You might see pleural effusions. You might see atelectasis, what we call linear atelectasis. So the part of the lung that is collapsed form like linear lines. And you might see focal area of opacities because of the blockage. Okay, but these are non-specific signs. Okay, a more specific findings in a patient with pulmonary embolism, should there is finding, these few signs. You can see raised hemidiaphragm. So raised hemidiaphragm. Okay. You can see what they call Hampton's hump. Hampton's hump is because of the area of infarction. It is a wedge-shaped density, usually is above the diaphragm. Okay, you can see what we call Westermarck signs. Westermarck signs is the area near the obstruction, the area in the lung near the obstruction in which it is more translucent. Okay, with area which is less opaque and more translucent because of decrease in vascularity. So they call it Westermarck sign. Another sign is what we call Pala sign, which is caused by enlarged pulmonary artery, large descending pulmonary arteries. Okay, so these signs are more specific, but truly very rarely that you can get these signs. So we have the cartoons that illustrate all that. Okay, so that you can get some ideas. Okay, you can have enlarged pulmonary artery, this is your Westermarck signs. You have can have elevated hemidiaphragm. You can have pleural effusion, horizontal atelectasia. Okay, wedge-shaped opacity. Okay, because if there's infarct, if there's even infarct, it's very rare for you to get infarction. Yeah. Pulmonary opacities. Okay, so these are the findings of chest X-ray which you might find, but You don't really truly, most of the time the chest X-ray will be normal. Okay. So what are the investigations that you want to do? Okay, because we say the patient is hypoxia, probably you detected that the SpO2 is low. Okay, so you want to do arterial blood gases. Okay, again, usually is normal. Usually is normal. Okay, but if it were to be abnormal, okay, you will have hypoxemia, low PaO2, hypocapnia, low CO2, so you have respiratory alkalosis. Okay, but usually again is normal because you have hypoxia and a patient are compensating for that. Yeah, because the body can still compensate for the hypoxia. Okay, so you have dyspnea and all that is all in order to compensate the hypoxia, right? So usually most of the time it's normal. Okay, but if should there is changes in blood gases, you will have this kind of changes. Okay, maybe a normal saturation, slightly normal saturation. 40% patient have normal saturation, still half of them are. So you will have abnormal SpO2 saturation, but your ABG will still be normal. Okay, hypoxemia, but if abnormal, you can see hypoxemia, hypocapnia, respiratory alkalosis. Okay, another way of looking at whether there's pulmonary embolism or not is you want to calculate the alveolar arterial oxygen gradient. There is a formula to that. Okay, there is a way to calculate the alveolar oxygen. Arterial oxygen is from your ABG. Okay, so the gradient usually in pulmonary embolism, the AAO2 gradient, alveolar arterial oxygen gradient, is high. Yeah, high, right? Because you have oxygen alveolar more than your arterial, alveolar oxygen is always a lot more than your arterial oxygen. Okay, so usually in PE it's high. Okay, which is about 15 to 20. Okay, however, it is found that about 20% of patients with PE, you can still have normal AA oxygen gradient, alveolar arterial oxygen gradient. So it is kind of useful, but you bear in mind you will still have a lot of PE patients with normal arterial oxygen gradient. Okay, all right. So that is blood gases. Okay. ECG findings. Okay, you can do ECG. Of course, patient with dyspnea, in fact, if even they also have chest pain, for example, you want to do ECG. Okay. In fact, ECG again is another cheap, easily available investigation, and is very informative because it can rule out dangerous condition. Okay, because it is actually more useful to rule out MI rather than anything. Okay, so in pulmonary embolism, okay, again, usually your ECG is normal, non-specific findings, but there are specific findings for pulmonary embolism should there be any changes. Okay, you can just probably have sinus tachycardia. Okay, what is sinus tachycardia?
Regular elevated heart rate or rhythm.
Okay, regular elevated heart rate. So you will just find that Hang on a second. I need to take. Okay, sorry. So sinus tachycardia, okay, because usually when I ask my students, if when I ask what sinus tachycardia, they will explain so many things because of the word sinus there. Okay, but actually it's just tachycardia. So you have learned your ECG, yeah? Okay. ECG is important also because usually MI, ECG, you have to know for your pro, at least you have to know um, your ST elevation. Okay, this is selingan je lah. Okay, this is bonus for you. Know your ST elevation. Know your, at least your atrial fibrillation. Okay, atrial fibrillation. Usually ST elevation lah. You have to at least know how to describe ST elevation and identify it on ECG. Okay, that is something else. All right. So sinus tachycardia just mean that the heart rate is high. So that means you have a normal PQRS complex. It's just that it's very close to each other, right? You know how to calculate your rate, right? So if your PQRS is normal and it is close to each other, that means the rate is high. So it is a sinus tachycardia and it's regular. Okay, so that is called sinus tachycardia. So usually you will look at it at your lead 2. That is at your long lead 2. Okay, another typical finding. So you can have sinus tachycardia. You would expect to have a sinus tachycardia if you have high increase in heart rate. So no other changes, no ST elevation or T inversion or whatever, but you can still have sinus tachycardia, so that's normal. It just shows that your heart rate is high. Okay, but what typical finding in pulmonary embolism, which you might find, but you don't always find. Okay, but if you have this, so this support your diagnosis of pulmonary embolism is what we call S1QT33. S1Q3T3. What is S1? So that means you have deep S wave in your lead 1. You have deep Q wave in lead 3, and you have T inversion in lead 3. Okay, so that is one. We have a look at this later. Okay, and if you have right ventricular hypertrophy or increase in right ventricular pressure, okay, you have hypertrophy. So you will have the finding which indicates there's right ventricular strain in that in the ECG. You will find this. You will find T inversion in your V1 to V4. Okay, so that the V1 in V4 is for the right ventricular. Okay, so you will have T inversion of your V1 and V4. So these are the S1, Q3, T3 are the typical finding for pulmonary embolism. Okay, T inversion V1 to V4 indicates right ventricular strain. Okay, so these are the findings that you may find, although, mind you, it might still be normal in real life. Okay, so if you have this, good. So this can support your diagnosis. Okay, so you have deep S wave in lead 1. So this is lead 1. Okay, so you look at your lead 3. So you know your PQRS, right? Okay, so you have a Q wave in lead 3. Okay, T inversion in lead 3. Okay, and this is V1, V2, V3, mana V4, V4, you have T inversion, right ventricular strain. All right. Okay, if this is not clear, you go and Google and you look for Q1, S1, Q3, T3. There's a lot of examples of it. Okay, so that is ECG findings. Again, it might still be normal, right? Another test that you can do is D-dimer. Okay, what is D-dimer? We have done this before. Have we done this before? Did you learn about D-dimer? Did you learn about D-dimer in your
Yes,
general paper? Okay, so what is
yes.
D-dimer?
It's a byproduct of breakdown of fibrin from fibrinolysis. When plasmin breaks down
Okay, so
fibrin, you
it's
get D-dimer.
all right. So it's a breakdown product of your fibrin. Okay, so you know what forms your thrombus. What form the thrombus? What are the content of your thrombus?
Fibrin,
Anyone? Fibrin. What else?
platelets,
Platelets. Yes, and
red blood cells.
White blood cells.
okay, so yeah, red blood cells, platelets, and mesh of fibrins. Okay, the mesh of fibrins. Okay, so whenever you have that, whenever you have coagulation, okay, you will always have fibrinolysis process occur hand in hand. Okay, so D-dimer is a test to show, so you're right. So D-dimer is actually the product of degradation of fibrin. Okay, so whenever you have fibrin formation, it will be degraded. Okay, because so it just a balance between degradation and formation of clots and degradation of clots. Okay, so in normal life, whenever you have clot, you will have degradation of clots. So you will have fibrinolysis occur hand in hand with clot formation. Okay, but the thrombosis will occur if this process is imbalanced. Okay, so we know that. We have talked about that. So when there is more clot formation compared to the fibrinolysis, then you will have clot. Okay, otherwise in normal life, because clot is you will have clot inflammation and all that, so the clot will eventually be so the clotting and the fibrinolysis action will occur hand in hand to stabilize. Yeah, all right. Okay, so but we say when there is thrombosis, that means there is some imbalance there. All right. But what we are testing here, when we test for the presence of D-dimer, is just to show that there is clot formation there. There is formation of clots, that's all. It's just, so it is actually very non-specific, okay? But it is very useful, okay? So it is, okay. So it is high negative predictive value. So that means it is useful to rule out pulmonary embolism. So that means it is useful when it is negative, which means that there is no pulmonary embolism. That's what it means, high negative predictive value. But the moment it is positive, you can't really say that is PE. Okay? It might support PE, but you can't be sure that it's PE because it can be positive in the list of other causes, malignancy, even pneumonia, because it's just show that there is the process of clotting going on there, only that. But if it is negative, you can be quite sure that there is no PE. Do you get that? That is the role of D-dimer. Okay, it is non-specific in the diagnosis, but it has a high negative predictive value in which if your D-dimer is negative, you can be quite sure that there is no PE because there's no clotting occur. All right, so that is the role of D-dimer. So this diagram shows where D-dimer is. It's actually the components of the mesh of fibrin that bridge all your fibrins together with the blood clots and all that. So when there's this fibrinolysis, the D-dimer is still intact, in which you can measure. Okay, so there is other fibrin degradation products that you can also measure, but D-dimer is easily measured, okay, and is still intact when there's fibrinolysis. Okay, so clear. Okay, so D-dimer can be used, but it is more valuable if it is negative to rule out. Okay, so other important investigations that can be done is what we call a VQ scan. Okay, so VQ scan is when you can see, so there are two arms for that. One, you look at the ventilation scan, so that means you give some sort of tracer, inhale, and you can see the whole area of the lung that are ventilated, okay, and then you can inject something to see the area that is perfused. Okay, so as you can see here, there are some area that is not perfused, okay, as compared to area of ventilation. So there is some mismatch between the ventilated area and the perfused area. Okay, so you can see here the whole area of the lung are well perfused, but the whole area of the lung are well ventilated, but their area of the lungs of the same person, this is the area of the same patient, okay, so this is the ventilation, this is the perfusion. Okay, so there are some area which is not well perfused. So there is a mismatch between the ventilation and perfusion. Okay, so that you can see in a ventilation perfusion scan. Okay, so so if there are two or more segmental mismatch, then probability there's a PE. Okay, but again, VQ scan is not readily available in many centers here in Malaysia. Okay, maybe, but there are certain centers that you can have VQ scan, but it's not something that is readily available as well. Okay, but if it is available, then it might be a good way to diagnose PE. All right. Okay. Another important and more reliable is what we call CT angiogram, CT pulmonary angiogram to be exact. So this is done most of the time is if you highly suspicious that this is pulmonary embolism. Okay, because you will learn later that pulmonary angiogram is a gold standard. Pulmonary angiogram is a gold standard for you to detect whether there's pulmonary embolism or not. Okay, so so you can do pulmonary angiogram in which you inject dye in the vessel and you can trace the whole flow of the pulmonary vessels. Okay, which is good. Okay, but a more reliable way is when you combine CT, which is a CAT scan, with the angiogram. So you can see with a better resolution. You can see the different section of the lung with a better resolution. Okay. It is more sensitive for pulmonary embolism within the proximal pulmonary artery. So you can detect embolism in the central part of the artery better. But if the embolism is at the periphery, you might still miss it actually. But this is CT pulmonary angiogram is used a lot in real life, and it is a good way to diagnose pulmonary embolism. But it still tend to miss if you have a small emboli at the periphery. Okay, but it is actually the way of diagnosing pulmonary embolism now in the ward, in the guideline. Okay, you do CTPA. Okay, so it's a combination of angiogram and CT scan. Okay, I'm not sure if you can appreciate, if you can see this is your pulmonary artery. Okay, so you can see the area which is more opaque here, okay, which is less bright. So that is actually where the embolism is. Okay, so you can see it clearly from so this area here with the CT pulmonary embolism. Okay, gold standard is pulmonary angiogram, in which you can see the flow, and you can easily see also you can easily also see the distal part of the angiogram of the flow of the blood. Okay, like here it's not so clear, but if you can appreciate, you can see the line here. There is actually an abrupt lack of filling of these pulmonary vessels. Okay, but the way to go now is actually CTPA. Okay, the problem with pulmonary angiogram and CTPA as well, because that's angiogram, is you have to give contrast. So if you give contrast, you need to be very careful with the renal profile. Okay, a patient with a good with low GFR, you cannot do this test. Okay, and if you do this, you have to really monitor the renal function. Okay, because if the GFR is not good, then you cannot get rid of the contrast. Okay, so it will lead to renal failure. All right, you will appreciate that better when you learn urinary. Okay, but the contraindication for angiogram, whether it's CTPA or this pulmonary angiogram, is patient with low GFR. Okay, but that is the gold standard, the angiogram, and here now is CTPA. We use CTPA. Okay, so this is the flow chart on sort of how we go about diagnosing. Okay, we have 7 minutes more of diagnosing pulmonary embolism. There are many other ways of doing it. Okay, if you Google, you will see many ways. So this is very, very clinical. Okay, so I'm not going to go through this so much, but it is self-explanatory actually. So if you go by D-dimer, so it depends on how you go about. You can actually start with using the Wells criteria. You can start with using Wells criteria and see whether it's most likely or less likely. Okay, and you start investigating. But if you go to the D-dimer, if it's negative, then that's it. It's no PE. If it's positive, okay, then you still need to look at the risk. If it's low risk, you want to go through a few sets of investigations still. Okay, but if D-dimer positive and the patient with high risk, you want to look at the confirmation of diagnosis. If negative and high risk, you want to still investigate. You want to still have a benefit of a doubt, actually. So it also depends on the risk, okay? So if D-dimer negative and risk is low, so you have to forget about PE, okay? So there are a few ways of people. Some people, they want to go with the risk first, whether it's high risk or low risk. So basically, if it's a low risk, negative D-dimer, so that's it. If it's a high risk, you want to still, with or without D-dimer, you want to still investigate. Okay, so if CTPA is positive, you want to treat. Okay, so something like that. So it is more clinical. All right, so very quickly, we go for a treatment. So how do you want to treat this patient? Okay, so if you have diagnosed this patient with pulmonary embolism, okay, so how are you going to treat? Okay, so primary therapy, it can be primary therapy or secondary therapy. Okay, primary therapy, you're talking about you want to dislodge the emboli. Okay, this is in the case of the huge pulmonary embolism with hemodynamic consequences. Okay, those with low BP, especially. So you want to immediately remove the clots. So you want to give thrombolysis. Okay, you want to give thrombolysis. Okay, so you want to give drugs which can thrombolyze the clots, or you can do operation, which is embolectomy. You want to do a procedure which remove the embolus. Okay, secondary prevention. Okay, you want to give something that thin the blood, okay, to prevent further clotting to happen. Okay, because we say the small clot can dissolve by itself with natural inhibitors. So you want to prevent further clotting so that the clot will remain small and easy to dissolve and prevent further clotting. Okay, so you can give anticoagulants such as heparin and warfarin, okay, or you can give what we call IVC filter. Okay, all right. This is another guidelines. I'm not going to go through this, okay, but just to bear in mind, if you have hypotension, okay, so that is when you are going into shock, you want to straight go for the primary therapy. Okay, if patients are still normotensive, so maybe you want to look at the secondary prevention. Okay, anticoagulation alone. All right, so what are the anticoagulation that you can give? Okay, the famous one are your heparin. Okay, you want to give heparin. You have not learned hematology, so it is quite difficult for you, but just read through this because you have a bit of knowledge in the coagulation pathway. Okay, so you should be able to understand this. So heparin, there are two types. There are unfractionated heparin, or there is low molecular weight heparin. Okay, but they are heparin. So what heparin does is it basically inhibits antithrombin 3. So if you go back to your notes, your intrinsic pathways, your inhibitors, so antithrombin 3 inhibits these factors. Okay, so it binds to antithrombin 3, so it inhibits mainly thrombin, which is factor 2 and factor 10. Just remember these two. Okay, it can inhibits all this, but mainly these two. Okay, so it prevents further thrombus. So mainly factor 2 and 10. Okay, so it works. So it inhibits more of your intrinsic pathway. Okay, all right. So you can give IV heparin. Okay, Another option is for you to give low molecular weight heparin, which you can give subcutaneously. Okay, low molecular weight heparin have advantages because it is easier to use, okay, and it has longer half-life, okay, so that you don't have to monitor APT. So because when you give heparin, you want to monitor your APTT. Okay, did you all learn this in general patho? I forgot. Yes, no,
About APTT?
yeah, no.
Yes.
Yes, kan, ada kan. So APTT is for you to monitor your intrinsic pathway, okay, because the heparin inhibits your intrinsic pathway, so you monitor your APTT, okay. So the advantage of low molecular weight, it has longer half-life, okay. It can easily reach your the anticoagulation that you need, okay. You don't need to monitor APTT quite often, okay, and you will have less incidence of bleeding, okay, because the side effect of heparin is bleeding, okay, major bleed, okay. So with low molecular weight heparin, there is less incidence of bleeding, okay. Another side effect of heparin is, I didn't put it here, is actually heparin induced thrombocytopenia. Okay, so you really have to monitor your platelet. Thrombocytopenia is low platelet. Okay, so it can increase bleeding because of thrombocytopenia induced by the heparin. Okay, so that is the disadvantage of heparin. But you do give heparin because it actually act quite fast to thin your blood. Okay. All right. So another anticoagulant is your warfarin. Warfarin is vitamin K antagonist, so it works through vitamin K. So it inhibits these 4 factors. Okay. In the notes that I gave you, I put there factor 5. So there was an error. I will give again this one. So it's actually factor 2, 7, 9, 10. Okay, so factor 7 is more of a extrinsic pathway. Okay, so others are protein C, protein S, but mainly it inhibits this. This is a vitamin K dependent anticoagulant. This SAP2 is your thrombin. Okay, so factor 2, factor 7, factor 9, factor 10. Okay, let me just go back here. Okay, the problem, the difference between low molecular weight heparin with the unfractionated heparin is low molecular weight heparin is more selective. It inhibits directly your factor 10 without going through your antithrombin. Okay, this fractionated, it binds to 83. Okay, so low molecular weight heparin is a more selective inhibitors of factor 10. Okay, so that is another difference. Okay, sorry. So go back to warfarin. So warfarin, different with heparin, it takes 2 to 3 days. In fact, it takes actually 5 days to reach anticoagulation. Okay, but it is a mainstay for a long-term anticoagulation treatment. So patient with PE, you want to give them a long-term treatment of anticoagulant, okay, for about 3 months or so. Okay, so they need to be on anticoagulant for 3 months. Okay, so what we do usually, we give heparin and warfarin together. We give heparin and warfarin together. The heparin will act first. Okay, and then after a few days, the warfarin will act. Okay, so once the warfarin will act, you want to remove your heparin. Okay, because heparin, we say it has a lot of side effects. Okay, so with warfarin, what you want to monitor, if you want to monitor the PT or INR. Okay, so PT is the main thing. Okay, so measure your extrinsic pathway, okay, but it is calculated in the form of INR, international normalized ratio. I think we talked about a bit about it in general pathology. Probably we'll talk about this again in hematology. Okay, so just remember, warfarin you monitor INR, which is your PT. For heparin you monitor your APTT. Okay, that should be fine for now. Your APTT measure your intrinsic pathway, your PT measure your extrinsic pathway. Okay, so you want to aim at certain value of INR, usually INR of more than 2. Okay, your higher the INR or the longer your PT, meaning the thinner your blood, right? So you want to maintain it at certain level. So the aim for patient with PE, when you give warfarin, so warfarin is a mainstay for the long term. Okay, heparin is only for short term. Okay, so after a few days, when the warfarin starts to kick off, you want to remove your heparin, so the patient will go back with warfarin. Okay, so but the patient has to come for monitoring of your INR, so you want to aim the INR of more than 2 usually. Okay, if it's less than 2, then you want to work with the dose of the warfarin. Okay, but you don't want it to be very high because there is a risk of bleeding. Okay, so that is the anticoagulation treatment. Okay, for thrombolysis, thrombotic treatment, okay, you have learned this in cardiovascular, right? Streptokinase, your recombinant RTPA, kan? Thrombolysis lies the existing thrombus. Okay, so it is more indicated in a patient with big thrombosis with hemodynamic consequences. Okay, so you want to give RTPA. Okay, so only for massive PE. Okay, so it rapidly reverse the right heart failure if it's there, and it can reduce there. So how it works, your RTPA, it blocks your, it activate your plasminogen. Okay, so activate your plasminogen, so you increase your fibrinolysis. Okay, so it is explained here. Okay, so it dissolves the arterial thrombosis. It also have other effect, that is they prevent the serotonin or neurohormonal substances, okay, which we say is also released with in large PE for especially. Okay, and it also release the thrombus in other places besides the lung. Okay, in your pelvic, in the left lower limb, other places. So it also prevent the recurrent of PE. Okay, but again, risk of hemorrhage, especially intracranial hemorrhage. So you really need to tailor down to monitor the patient. Okay, so those the main one. Others, we talk about the IVC filter. This is how it looks like. You can give the filter if you cannot give anticoagulation. Okay, so the indication is if you cannot give the anticoagulation, for example, in a patient with active bleed or with recurrent and in a patient with recurrent thrombosis, okay, despite anticoagulation, so that means patient who you cannot give anticoagulation, or if anticoagulation doesn't work, you can think of IVC filter. So you give it, so it will be there and track all the thrombosis. I'm truly not sure on the utilization of how common we utilize this method. I'm not really sure. Okay, so embolectomy, we say it is indicated for a large pulmonary embolism, okay, in which thrombolytic measure doesn't work. So you want to go in. Okay, so this one you want to save it for last because it's invasive procedure. Okay, so that's all. Any questions? Okay, if there's no question, thank you very much. I will actually email you this one. There is only slight changes just now. Okay, but I will email you this in a group mail. Okay. Thank you very much, everyone.
Doctor, the attendance.
Oh, attendance. I didn't have the attendance. Did Dr. Kodos give to any one of you? Okay, so
Yeah,
you have
give
you
us
have
the
the link. Okay. Oh, I was supposed to tell you when to release the attendance, right? Oh my God, sorry. Because there are so many ways of how the lecturer do this. I was not informed. Okay, so please, attendance. Yes. So how do you do it? So you put it in chat, is it?
Yeah, it's a link.
Okay. All right. So everyone who are here, please don't forget to sign your attendance. Okay. Thank you very much.
Thank you, Doctor.
Thank you, Doctor.
Welcome.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.